Dear esteemed and cherished patients, dear patient representatives, dear interested and dear relatives, I warmly welcome you to our interview today, in which we will present the highlights from the ESMO Congress 2024 on the important topic of advanced prostate cancer. And perhaps a very brief introduction about myself. I am the head of the Prostate Cancer Support Group Berlin North, and what is always important to me, and I emphasize this repeatedly, only thoroughly informed and knowledgeable patients can make fully good and reasonable decisions about their further course of therapy and treatment. That's why we are doing this here. So as mentioned, today we will report on advanced prostate cancer, discuss it in detail, and we want to know how it affects our everyday treatment practice. And for that, I have the renowned Professor Merseburger as the absolute expert in this field of expertise by my side. So Professor Merseburger is actually the director of the Department of Urology at the Lübeck campus of the University Hospital Schleswig-Holstein. He is a neurologist and, importantly, an esteemed member of the European Guidelines Commission. I am truly very glad and happy that he is here today. And together we have carefully selected a few studies that we will discuss afterwards. Okay, so I will now hand over to you, Professor Merseburger.
Mr. Kronewitz, thank you very much for the kind words and the introduction to the topic. I believe it is very important that we communicate much more, and perhaps also in a format like this, and that we discuss the latest discoveries rather than relying solely on the internet, which is always difficult to thoroughly investigate. Therefore, we have taken the effort to bring the highlights on prostate cancer now from this year's European Cancer Congress for you. It is important, as it concerns studies, to show my potential conflicts of interest. As mentioned, there is a lot of involvement in clinical studies. And it is always the case that these are the latest research findings, which sometimes have not yet reached the clinic, but show a certain trend. And they are sometimes even implemented in the clinic the very next day. That varies greatly. And we brought along a few things that we found to be clinically relevant. A recent study was presented in the main international forum to thousands of colleagues by an oncologist. From Switzerland, from Lugano, Silke Gillissen, she has dealt with, I'll click one step further, the so-called PIS3 study, specifically in men with prostate cancer, which has spread to the bones and is castration resistant, already under ongoing hormone therapy and then further growth. And here it was officially approved, the enzalutamide, and it was investigated in this study whether enzalutamide can be combined with radium at an earlier stage. So the hormone deprivation therapy continues, plus enzalutamide plus radium-223, which is a medication similar to radioligand therapy, except that, unfortunately, it simply does not work in lymph nodes or liver metastases, but only in the bone. Therefore, the patients in the study also needed bone metastases. The endpoint was radiographic progression-free survival, that is, how long the disease was blocked, and also as a secondary endpoint, the overall survival.
Sorry, unfortunately, there was an unfamiliar word on it, which I believe is not familiar, not only to me, but perhaps also to our dedicated viewers. So what exactly is antineoplastic therapy?
It's good that you asked that. We should have written it better. On the slides, that is indeed anti-cancer therapy. Neoplastic essentially refers to the process of new growth, so it is a form of therapy targeting cancer.
Thank you very much.
All right. So essentially, the longer this time period until the following chemotherapy, the better the outcome for the patient. That's it.
Definitely.
Here are these two arms once again. Does this potentially lead to a slowing down of the cancer? In this case here, prostate cancer. The study was highly positive. The combination with enzalutamide plus radium actually resulted in an average of 19 months until progression occurred again, compared to 16 months with enzalutamide alone. So there is indeed a very big difference between these two arms. You can see then it is compared after 2 years, so after 24 months. And there you can clearly see the difference. And the exciting part is that the whole thing also translates into a survival benefit. 35 months of enzalutamide and 42 months of the combination. And we have already discussed it before. How long do the patients live? Or in the situation, you can see that in the aggressive prostate cancer situation, survival can be around 3 to 4 years. And theoretically, you can gain a year with this combination.
That is indeed significant, yes.
Now, I'll move on to the next page. What about side effects? And they were comparable. There were not many more additional side effects as a result, and why it was very important that all patients also receive bone strengthening. So indeed, osteoprotection is important, and that is what I would advise all of you for patients to ask the doctor if you can receive bone strengthening treatment once this castration-resistant tumor stage is clearly reached. We can also slide back again. But let me summarize. What does this mean for everyday treatment practice? For me, this means that the combination of both with this bone strengthening is safe. So there are no more side effects, and that the time until the disease progression is extended. Also, the survival. Now, of course, one must see what happens if everyone rushes to their urologist saying, "Can I get that?" One must consider that the study is not yet fully published. So we only have this abstract. We have to wait for that. The medication has not yet received approval. And indeed, it was developed at a time when we were still treating in a very different way. Now we have radioligand therapy, now we have PARP inhibitors, now we have chemotherapy. So in that sense, it is certainly a fascinating and exciting concept. But I would, if I were well managed, not switch treatments for prostate cancer. At least I know that when radium-223 is given, one might consider continuing enzalutamide or to combining it with.
I have to say that this still sounds quite positive despite everything. The question here would be, what is the approximate time frame until something like this is available for all affected individuals?
I really think it actually depends a little bit on whether you achieve an approval extension through the European Regulatory Authority. First, it must be fully published. There we have seen some of these EORTC studies. One was shown at ASCO last year, but it has not yet been published. So it can also take months to years. The medication has already been successfully approved. So I would rather expect it to take a year or even longer to determine whether the extended approval will be applied for. Sometimes that happens. There are great studies, well done. But nothing changes because in the meantime, the treatment has changed significantly. And maybe I'll continue now because that is exactly the right cue. The treatment has changed. A few years ago, we only provided hormone deprivation therapy for metastatic prostate cancer. Then a few years ago, we saw that a dual hormone therapy had a better effect. And in this study, let me tell you, the hormone deprivation therapy, hormone sensitive, was investigated against the combination of hormones and darolutamide. You may know darolutamide from the triple therapy. It is indeed approved there in combination with chemotherapy. And we have the medication that is quite similar to enzalutamide and the apalutamide, where it can be used in combination therapy. We did not have any data here until now. And now there is the study that compared it, placebo and hormone therapy alone or dual therapy. And if you look at this, as you can see, these two arms, then you can see a clear difference here in the progression-free survival. 50% experienced further progression of the disease after approximately 2 years compared to around 70% who had no progression. So this really is a huge difference, a 20% difference between these two arms. And this supports that the dual hormone therapy continues to have great significance in prostate cancer. Currently, darolutamide is only approved for use in triple therapy. Here, I expect a bit sooner rather than later, an extension of approval for this dual therapy, where one might then be able to skip chemotherapy. What is still pending is the overall survival. Here, we have not yet had follow-up checks for long enough at this point in time. So the follow-up period with 2 years is not long enough yet. We must wait for further results in the coming years to see if overall survival is also extended. What about side effects? This is very important for you as affected patients. It shows that the dual combination therapy is in principle just as comparably well tolerated as hormone deprivation therapy alone. Here, it is a very effective therapy. I myself am hoping for an expansion of approval of darolutamide so that in the future we can use darolutamide alongside triple therapy, but then also without the chemotherapy.
Is this generally suitable for all patients without any restrictions? Or for whom would you perhaps recommend this therapy now?
Mr. Kronewitz, we did not coordinate with each other, but you always ask the great questions that fit perfectly. I believe one has to see that when you have a very young patient with liver metastases with a very poor prognosis, a very aggressive tumor, I find the triple therapy still very useful with chemotherapy. But I would say that in about 80% of the patients, one could start with this therapy if it is approved, similar to apalutamide or enzalutamide in combination. And 20% of the affected men who are at high risk of dying from a disease should perhaps be all in from the beginning with chemotherapy. and the hormone-hormone combination.
Good. Yes, thank you very much for the information.
Then at the end, we have something exciting. That was also a so-called late breaker, meaning submitted at the end with exciting phase 3 study data on hormone deprivation therapy, and here the classic hormone injection, which you might know from the disseminated situation in your own experience, given every 3 months or a pill taken monthly or 6 months. There are different types and variations, was compared to estradiol, that is estrogen patches. And now this transdermal application, the adhesion of this estrogen, we know that this also lowers the testosterone levels, and in addition blocks the male hormones. That was already investigated 80 years ago when this hormonal axis was explored in prostate cancer. And here, non-metastatic patients with a rise in PSA levels were involved. So non-metastatic patients were examined. They have either received the classic hormone deprivation therapy or the skin-applied estradiol. The type of hormone therapy was indeed not approved, actually. And here, metastasis-free survival was investigated. So the patch versus the injection with a different active ingredient. This here on the right is the standard, the gold standard. This is the test arm, which is not approved and was investigated in the study. The curves are very similar in many aspects. The metastasis-free survival is equal. Normally, something like this is a negative study. In this case, not, because it shows that the curve is the same for estradiol as well. So we can say that it works in exactly the same way as the classic injection. The overall survival was also comparable over this period of time. So here, if you take a look right here, after the 8 years, 50% of the men were still alive. There are indeed other diseases as well that put us men at the potential risk of dying. The main risk is still the heart, cardiovascular risk factors, etc. And there is no difference here compared to the injections. But what has been observed, I have listed it here again. Men who frequently suffer severely from hot flashes might consider applying through their health insurance, as it is simply not yet approved to receive estradiol as an alternative. That was indeed the difference in this study. No difference in effectiveness, absolutely. Those patients who had these patches, they had fewer hot flashes, but instead had gynecomastia and more swelling of the chest bodies, meaning of the breasts and also breast pain. It is a different spectrum of side effects. As mentioned, not yet approved. I found that quite interesting. I personally do not treat with it yet because we have not approved it yet. But when we have hot flashes, I have now found out that oxybutynin is quite good as a medication, which is also approved in urology. So in that respect, quite exciting data now regarding the alternative to classical hormone therapy as a treatment option. I'll hand over to you, Mr. Kronewitz.
Yes, well, I really have to say, yes, we really did not coordinate with each other. You have to believe us. But that would have been my question as well regarding side effects. That is always very important to me as well. And you have already answered that. So thank you very much. Here, it would always be important for us to know for whom is one option suitable and for whom is the other option suitable. Because if the side effects of both options are indeed roughly comparable, and in addition also the, well, let's say, the curves that we can see here, that, as we have seen, are also comparable, then the question always arises, for whom do you give one or the other? You have already partly explained it regarding the hot flashes. What about other potential side effects?
Yes, so perhaps it is important to say again that this is the first major study that has examined this in such a way. And we have, regarding these hormone preparations that are approved, several large phase 3 studies for all preparations. So you can't compare that. This is now a brief snapshot in comparison to the large-scale studies about the approved medications. That's why they are approved. And something that I would do for the practice, and the differences are just, we have more hot flashes under the classical hormone deprivation therapy. These hot flashes, like the sudden onset of sweating, this is not usually the case with estradiol. However, there are problems with breast gland swelling and chest pain, nipple pain that can occur with it. So what exactly would I really do? I would stick with the approval and use the GnRH agonists or classic antagonists that are approved for advanced prostate cancer. And if then side effects like these hot flashes occur, then I would try oxybutynin, for example. This is also approved for overactive bladder, which also affects many men. Well, it is a urological medication, which makes it quite charming. There is data showing acupuncture can help with these hot flashes But Mr. Kronewitz, you have a few ideas as well. And if all that doesn't help and the man needs the hormones, but still suffers from it, one can certainly also, using this data here, write with your urologist a health insurance application, asking if the more affordable estradiol can be used instead. And I'm curious, well, the data is very fresh now. I have no experience with the applications yet, but that might be worth testing.
Yes, that would also be an appeal from my side to all patients. Just to ask here, perhaps the urologist or maybe the oncologist, to ask if there are resources available in general. This applies not only to this study that significantly reduce the side effects, because there are indeed many things, medications, and there are not only, let's say, different types of medications, because many people are always afraid, but there are actually also things that are from naturopathy. And by that, I mean serious complementary medicine that are also suitable for it. One should also get informed about that.
I think that's good. And those were such incredibly exciting studies. And once again, such an expression. There are, of course, a lot of new things that are shown at such a congress with 35,000 participants. And the important thing is now that we incorporate this in the medical field and include it in the research, in the clinical study. And you can believe us that we also do this in practice, and that is what is truly relevant in practice. We are the first to bring this to the patients. We want to bring this to the patients and then also support you with health insurance applications. Perhaps it is also important to mention again, not to clutch at every straw. When we say this is now phase 1 and not yet verified, it doesn't make sense yet to build trust. We don't want to sell you anything, but achieve the best possible for you and against your illness. This is our common goal. And at this point, I would like to sincerely thank you. Thank you for your attention. And I hand over once more to Mr. Kronewitz for a closing remark.
Yes, so thank you again for the presentation of the truly interesting studies. I find it just unbelievable anyway. What a truly vast array of studies there is. Also specifically regarding prostate cancer. And that is absolutely incredibly important for us. Very well. So, and now I can only very, very warmly ask you to then also gladly watch the other available videos on the advanced prostate cancer. And now I say goodbye. Thank you once again very much, both for the attention of the patients as well as the patient representatives, interested parties, and of course family members, which are often neglected, I must emphasize that, and much more should be done there as well, towards areas such as psycho-oncology and so on. But I don't want to go on any further now at this moment, but also to thank you again, Professor Merseburger, and then I wish everyone to stay healthy and safe.